Hello, everyone. I'm Vanessa Cartagena, Meetings and Events Associate here at America's Essential Hospitals. Thank you for joining us today and welcome to today's webinar, part of our COVID-19 webinar series, Graduate Medical Education During the COVID-19 Pandemic. Before we start, I want to recommend you use the dial-in number displayed on your screen to listen to today's presentation. Because COVID-19 is causing high internet usage, you might experience interruptions if you try to stream the audio portion of this webinar on your computer. So to ensure a trouble-free experience, we recommend you use the dial-in number for audio as you watch the presentation on your device. Also, like many of you all of us here are working remotely. So please bear with us as we adjust to the challenges of producing a webinar from multiple locations. I wanted to take a moment to point out the webinar section of our website at essentialhospitals.org. You'll find upcoming and recorded webinars under the Education tab of our website. Once there, look for the webinars link in the menu just under the photo. As a member, you have full access to the rich library of recorded webinars on our site. Today's webinar is being recorded and will be available on our website by the end of the week. Today's slide deck is also available for download on our webinar page. To ensure you can interact with us today, please make sure you have selected both the participant and chat tabs on the right-hand side of your screen. Although your line is currently muted, we can open it if you have a question for our presenters during the Q&A portion of today's call. If you want to ask a question, please use the Raise Your Hand feature at the bottom of your participant panel. We will unmute your line and announce you by name. Now, I'm very pleased to introduce today's lineup of speakers. They include a member of our staff here at America's Essential Hospitals, Jennifer Stevens, Principal Researcher. We're also excited to have a few guest speakers from our member hospitals join us today. From Accreditation Council for Graduate Medical Education, Paul Foster Johnson, Executive Director of Institutional Review Committee. From SUNY Downstate Health Sciences University, Teresa Smith, Associate Dean for Graduate Medical Education and Affiliations, and Designated Institutional Official. Now, I will turn the call over to Jennifer, who will kick off our presentation today.
Thank you so much, Vanessa. Next slide, please. I also want to take a moment to say thank you. Perhaps you haven't heard it in several days or you've heard it a lot, but that doesn't mean that it's no less meaningful to hear. All of us at America's Essential Hospitals want to say thank you because we're grateful to each and every member of your hospital staff. We want to say thank you for your commitment and to your sacrifice in the face of this deadly pandemic. Next. Part of our way to say thank you, we're here to support you now more than ever, to be a voice for equity and effective healthcare, to help you secure funding, to disseminate best practices and innovations, and to facilitate member-to-member knowledge transfer. To help us do that, we have a number of resources available to you. Next. You may have seen that we recently opened access to register for Virtual Vital 2020. We hope you'll join us in August for our annual conference to connect with essential hospital peers and gain insights from industry leaders. This virtual event allows us to provide the exceptional content we do every year, but to do so safely. As a bonus, there's significant savings included in the registration this year, and you don't have to make any decisions about what content you want to engage because all of the content will be available on demand after the event is over. It's also important to note that this event is open for registration today. You simply can go to vital.essentialhospitals.org. You can take a look at the educational sessions as well as the full agenda and register there. Next. We also continuing to engage in ways that you're familiar with, whether it's through our federal and state newsline articles, our latest from Action, updates on policy, and action alerts to spur legislative activity. You've probably seen some new avenues for us to engage specific to COVID-19, including weekly COVID-19 updates that happen on Fridays that include links to policy updates, new resources, members in the news, and upcoming webinars and calls. There's this COVID-19 webinar series coming up. We are planning a mini-series on disparities and a policy and legislative update. And there's also our COVID-19 email list. Next. you haven't already, you can register for the email list with the link shown on the page. And this way you'll be able to engage with your fellow member hospitals, as well as the staff about any questions related to COVID-19 or to share resources with your fellow members. Next, there are a number of resources available from members, from states and nonprofits, and others. If you go to our website, essentialhospitals.org, and click the red toolbar in the middle of the page, you'll go to our overarching resource page, next, where you'll be able to access and or submit resources. These resources range from a number of topics, including financing, care for specific populations, infection control, privacy, etc. Next. Today we have a very exciting webinar, as Vanessa mentioned. We have staff from ACGME who will talk about the institutional accreditation during the COVID-19 pandemic and how that may need to flex and how to do that for your organization. Following that, Dr. Smith from SUNY Downstate Medical Center will walk us through their pandemic response in New York. We'll have time at the end to hopefully engage in some exciting discussion where you'll have a chance to share your experiences and ask questions of our speakers. With that, I'm very honored to introduce Paul Foster Johnson from ACGME. Next.
Thanks very much. It's a great pleasure to be with you today. I really appreciate the opportunity to share some of the work that ACGME and the GME community have been doing during the pandemic. I'm also really happy to be here with Dr. Smith, whom I've gotten to know kind of during the pandemic period. And she's a GME leader who's been on the front lines in Brooklyn, and I just know that she is going to have some really interesting insights into this period and can tell you a lot about what has been happening kind of on the front lines, and we are a little bit removed as accreditors from that. So thank you for the opportunity to co-present today. Next slide, please. So for those of you who may not be fully acquainted with us, we're the Accreditation Council for Graduate Medical Education. We are the accreditors of residency and fellowship programs for physicians in the United States. And a lot of the program accreditation work that we do takes place through what are called specialty review committees that are specific to internal medicine, surgery, and other specialties across the spectrum. The space that my team occupies at the ACGME is institutional accreditation. Programs have to be in ACGME accredited sponsoring institutions that comply with our ACGME institutional requirements. And sponsoring institutions are a term of art that we have created. Really, there are many types of entities that are accredited by us as sponsoring institutions, and our requirements are flexible enough to allow for a number of different structures to meet these requirements. They include hospitals, health systems, medical schools, consortia, FQHCs, and a number of other models. It's a very diverse array of sponsoring institutions that we accredit. And institutions, what they have in common are that they have to have authority for the programs that are accredited by ACGME, and they have to provide oversight. They have to ensure resources that are available to run GME programs adequately. And designated institutional officials, or DIOs, like Dr. Smith, are our main point of contact in the institution. And there's an increasing kind of professional role definition associated with DIOs over time. We also interact with senior administrative leaders, committees, governance, and institutional coordinators in the institution. DIOs are the main points of contact for us, though, in institutional accreditation. Next slide, please. And so there are DIOs who compose the Institutional Review Committee, which I am staff to, and this is the peer review group that makes accreditation decisions about all 865 sponsoring institutions in the United States, and those sponsoring institutions are responsible for all of the 140,000 and more residents and fellows in the United States at any given time, and the 11,000 plus residency and fellowship programs. About 700 of those institutions receive annual accreditation decisions from this group here, and 2019-2020, that cycle of decisions are made on the preceding year of accreditation information. And so the decisions for this year were not really disrupted. The IRC is meeting virtually for the time being. We're really preparing prospectively, though, for the upcoming cycle, knowing that some of our indicators there will be changes to them that we have to adjust for. For instance, we do a national resident survey that was administered this year in part during the pandemic. And so at the institutional kind of aggregated level, we are going to have to really change how we think about the survey, and the IRC probably will not be using the most recent version because of some of those issues. So we're working on how to make the process work, knowing that some of our data is changing due to pandemic-related disruption. Site visits for institutional accreditation and program accreditation were paused for some time. Now they have been able to develop and test a virtual site visit process that's now being deployed, so site visits can now continue. And we're working collaboratively with ACGME program accreditation staff on some of the issues that continue to emerge. Next slide, please. And so accreditation requirements are very closely tied to residents' learning environments and the experiences that they need to develop competency in unsupervised practice after they are done with their GME. And ACGME has an extraordinary circumstances policy to manage educational disruption in those learning environments where residents are unable to receive education in compliance with ACGME requirements due to some kind of disruption. This policy has been used a number of times, notably and recently in the case of Hahnemann University Hospital in Philadelphia, a very large sponsoring institution that closed last year. And the policy often involves a temporary or permanent reassignment of residents in a variety of kind of disaster scenarios. The pandemic has been very different in that it presented new kinds of disruption, and the scale has been unprecedented in the disruption to GME, and the emergence of that disruption has been rapid. So starting in mid-March, the ACGME offered some guidance to sponsoring institutions that were facing disruption due to the pandemic and published this guidance. It applies to sponsoring institutions, what you see here on the screen, the 3 stages of GME during the COVID-19 pandemic. And really, these stages move along kind of a continuum of trade-offs between what you see as business as usual, in quotes here, and patient care surge, and really strong increases in the demands for care of patients with COVID. So we allowed sponsoring institutions to declare stage 3 conditions in their sponsoring institution. And what did that do? It provided relief from enforcement of some ACGME program requirements. ACGME had made some changes in supervision definitions that included telehealth, and so those were implemented early under this. And a new requirement that was just starting to be implemented in some review committees about independent practice, where fellows could spend 20% of their time in a given year in independent practice, essentially functioning as an attending in their core specialties. That became applicable in stages 2 and 3 under this paradigm. All of the institutional requirements that we have remained in effect and were being enforced for institutions regardless of where they fell in this model. There were some limitations. This was developed very rapidly and kind of in advance of an understanding that disruption could take a number of different forms in clinical learning environments, and it didn't really account for prolonged disruption and a return to a stable state that may not be business as usual. The issues with residents' abilities to complete their programs and to become board eligible when they weren't able to get, procedural experience or the counting of patients and their continuity experiences. This didn't really accommodate all of that. So there were some changes that we'll need to tell you about in just a second. Next slide, please. So we started tracking the stage 3 declarations that we were receiving from sponsoring institutions on behalf of the DIOs. And the information about Stage 3 and the terms of the Stage 3 declarations are now internally visible to the ACGME Review Committee, the contextual information to help them to understand the extent of GME disruption when they're next reviewing programs. We track the information and have started mapping it, as you can see here. We provide this to the DIO community and also to ACGME leadership. This is kind of a recent map that shows that there's still a fairly prevalent disruption to GME in the Northeast, and particularly the New York City area, and in some places in the Midwest. We've spoken to a number of New York City DIOs about the current situation. I expect we'll hear more from Dr. Smith, but the return to normal has been slow, and there are some special considerations that we are still kind of learning about in that area. Next slide, please. We've also been able to give information about the programs under these sponsoring institutions. You can see about 10% is our what we have for the proportion that are still facing disruption. And next slide. And this is a visualization of the residents in those sponsoring institutions. And you can see some similar patterns, and the majority of residents in New York are still kind of considered to be in this state. Next slide, please. And we've come down from the high point of disruption so far, when it hit about 20% of the sponsoring institutions right at the beginning of May, and it's come down kind of quite a bit. We are not sure what the future holds. Next slide, please. And my boss, Dr. Kevin White, introduced us to this slide from SAMHSA. And the point here is to illustrate that the initial impact of the pandemic required some rapid adjustments, both at the ACGME and the GME community. And I think that we might need to think of an alternative illustration here, since I'm not sure that the disaster is unfolding in a linear way. But this is the important thing to note here is that we've kind of gone through the inventory period that you see here, and have seen a need for reconstruction, based on some of the limitations in the first model that I described. Next slide, please. So as of July 1st, the ACGME is now moving away from the stages 1 through 3 model to the emergency, non-emergency GME, the categorization for GME disruption in the pandemic. And this new framework offers ACGME policy mechanisms that do address prolonged disruption in sponsoring institutions and programs. It also continues to provide ongoing information to ACGME about disruption in sponsoring institutions, and hopefully addresses some of the limitations I was describing a bit ago about the time factor, the needs of learners, and the definitional issues with pandemic emergencies that we have seen. Next slide, please. And this is just a very crude crosswalk from that older stage 1 through 3 guidance into the binary new framework. Stages 1 and 2 are roughly equivalent to what we're calling the non-emergency category, and stage 3 crosswalks in a roughly analogous way into this emergency category. Next slide. And the non-emergency category is a passive state. No one has to declare this. The general assumption is that if you're not in the emergency category, you are in the non-emergency category as a sponsoring institution. And the one important change here is that the changes to the telehealth kind of definitions and our supervision definitions in our requirements has stuck and is now in effect. And we know from our conversations with DIOs that the last few months have seen a great transformation that very much affects GME in the use of telehealth in care processes that may really, going forward, have established a new normal in how some GME occurs. So that applies to all. And whereas there was some flexibility in this independent practice where fellows were functioning as attendings in stage 2 in non-emergency category, that is no longer the case. So that flexibility that door has closed to the non-emergency category. Next slide, please. And so now we are defining the emergency category for GME disruption as substantial, sustained, and pandemic-related, affecting GME operations. All of the institutional requirements in this new framework are in effect. As with the previous framework where there is some relief from program requirements when sponsoring institutions and their programs are in this category, there's a prioritization of requirements from the Commons around PPE and other safety concerns in the learning environment, work hours, and supervision as they're being viewed as core requirements that really cannot be suspended even in emergency situations. And in this category, there is a suspension of some accreditation activities. Programs won't get site visits if their institution is in this category for the term of that categorization. And there is some other things like milestones may not be applicable. Next slide, please. And so the process that goes along with this new framework really relies on the self-declaration from the DIO for the first 60 days of this when this disruption is declared. Then in the 61 to 90-day period, there's a bit more complicated process that involves a screening and potentially review by the IRC. And after that, the classic kind of extraordinary circumstances steps kick in. And this goes into effect July 1st. So this is day 1 of the new process officially. Next slide, please. As I mentioned, the first part of this categorization relies on DIO declaration, and they provide some details on a form to us. They attest to a number of things, including having the approval of the senior leadership of their participating sites. They attest that they've informed the GMEC, and they attest that they are managing the oversight of ACGME compliance with the requirements that are applicable to them in the emergency category. Next slide, please. The biggest change in this new framework is this 61 to 90-day period. That we realized that it's important to get more precision to understanding the nature of disruption when it goes on for this long, and ACGME is now subjecting it to a staff screening according to some indicators, and if the thresholds for those indicators are not met, the IRC will give a final decision about whether to grant this categorization. We give instructions in the form for lookup and of the first 2 measures, and instructions for how to calculate everything. And residents really at this stage need to be informed of any effects on their ability to complete their GME program, and also any kind of downstream effects related to board certification eligibility. Next slide, please. And so once the emergency goes on for 91 or more days, it really calls for intensive work between the ACGME and the sponsoring institution to understand a plan for educational restructuring that gets back to compliance with the requirement, or temporary or permanent transfer to get residents out of the environment where they apparently GME is not providing the commonly accepted forms of learning that are expected. And the DIO at this stage to provide attestations for what I've described before. So the IRC has done its first reviews in that 61 to 90-day period this week, and we're still making some marginal improvements to this process. The institutional accreditation team is trained up now and is starting to get a little more experience. And we really do think that this will be a more durable and a more transparent approach for the next phase of the disaster as we're seeing it continue. And so we have received a couple of new declarations declarations in the past few days from an institution in Texas and an institution in Florida. And so that may be a sign of what we may expect over the coming weeks. And hopefully this process will help DIOs and institutions to navigate some of the very difficult challenges that they will be facing. Next slide, please. So what I just described was very much within the accreditation space, the space of minimum requirements. The ACGME over the last few years has really embraced formative activities that are independent of accreditation. And I just wanted to take a little bit of time to describe a very positive development that has occurred during the pandemic. We came back from our annual conference right at the beginning of March, and at that conference we discussed a number of new initiatives that we were planning to engage DIOs and others in sponsoring institutions. And the pandemic very quickly provided us an opportunity to accelerate the schedule for some of those activities as we went into lockdown. And we started convening DIOs with some of in these activities with some of these goals in mind for the learning communities that we were hoping to set up. And there's primarily the primary goal is sharing and problem solving among DIOs in a collaborative learning kind of format. We also realized that we needed to understand the phenomena, the new phenomena that were emerging in the environment, and these conversations really helped us to respond in real time to what we were hearing from the DIO community at large. And very quickly there surfaced some new well-being needs that were kind of unique, and so this hopefully has provided an opportunity to foster well-being when in-person connections are not really possible in GME. Next slide, please. And so a range of activities really came out of this, from across our department. Institutional accreditation staff and other staff really joined us to support these activities that were concentrated at first around these weekly Monday calls where all DIOs were welcome to join. We also added Wednesday calls that were smaller and more kind of in-depth explorations of specific issues. We created an online resource library that DIOs can get to, and also started collecting well-being resources, housing some of the webinars that we put on in this period. Next slide, please. And so this just gives a sense of where the community has been through these calls over the last few months. So many new things related to, first there was the issue of medical students graduating early and how DIOs were grappling with that. Then all these new orientation issues. How do you bring new learners into the environment during the pandemic? And what's going to happen in the next recruitment cycle that really is just about to begin now, with audition electives and residency interviews, things that can't really happen in person in the same way. There's some very quick, very hard work to be done to try to create a new normal. The experiences of New York City DIOs, updates from ABMS, issues related to elective procedures in GME, well-being, and more recently, after the protests against police violence against Black people, we've started to convene conversations around racial equity and social justice as they intersect with GME, and that work you can expect will be carried forward into the academic year as a big focus for us organizationally. Next slide, please. And there are work products coming from a lot of these groups, these special topic groups. In addition to listening to the recordings and watching the recordings, there are lists of orientation topics, other things that the DIOs have been generating for each other that are really quite wonderful to see. And all outside of the traditional accreditation space. Next slide. And we have this online place for ideas to be shared. DIOs can submit to this. We also are loading it up with the items that we're collecting along the way and conversations we're recording so that everybody can engage even if they can't make a particular call. There's asynchronous engagement that we are starting to promote. Next slide, please. We also asked the DIOs very early in this journey to refer to us some of their well-being experts who have been convened not within our department, but under Tim Brigham, who's our Chief of Staff and Chief in the Department of Education of ACGME. This group has been doing really wonderful work, and we're hoping to create more linkages back to the DIO and institutional kind of groups in the next few weeks. We're also very interested, it's been really great to set up the infrastructure for this, and we are now eager to work with the DIOs on a model of co-leadership of these conversations that will only enhance what we're all doing here. Next slide, please. And so everything I've described is a slice of what the organization's been doing. We have participated in inter-organizational efforts such as those that are coming out of the Coalition for Physician Accountability with recommendations around transitions from medical school into residency and how to handle residency recruitment in the pandemic. And a number of other issues. Everything's available on our website. A lot of efforts are happening at the program accreditation level. You can find it all using this link here. And next slide. And these are ways to get in touch. On the left is my inbox. The institutional team inbox is on the right. Please feel free to utilize these. Even though we're having a discussion today, if you want to write to me, feel free. I look forward to hearing your questions live here, though, in this space. And with this, I will turn things over to Dr. Smith from SUNY Health Science Center at Brooklyn. Thank you so much.
Thank you, Paul. I greatly appreciate the opportunity to speak to the Essential Hospitals community, and thank you personally, Paul, for referring me for this talk and allowing me to be a voice for New York and more specifically Brooklyn. My name is Teresa Smith. I'm the Associate Dean of Graduate Medical Education and DIO at SUNY Downstate Health Sciences University here in Brooklyn, New York. I'm an emergency physician by training. SUNY Downstate is the only academic medical center in Brooklyn. We train residents and fellows at the University Hospital. One of our primary sites for most of our programs, actually, at our center is Health and Hospitals, Kings County. We also are affiliated with several other community hospitals in the borough of Brooklyn. We train 957 resident and fellows across 51 programs. Our population is diverse, largely coming from an immigrant patient population across the African diaspora, mostly, though, specifically the Caribbean islands. Each population has their own culture and history, which really does impact their health. The impact of social determinants of health are seen in every encounter with our patients. Next slide. So my goal today is really to set the scene of what did happen in New York and what's continuing to happen. I'll talk about our redeployments at SUNY Downstate, some of the lessons that we learned, and how we are facing two pandemics. Next slide. So to set the scene, we are currently in phase 2 in New York City. By phase 2, New York City has seen 200,000 plus cases of COVID-19, and we have had 50,000 plus hospitalizations. Next slide. To look more specifically at Brooklyn, by May 12th, Newsweek reported that Brooklyn had more deaths from COVID-19 than any other county in the U.S. If we look at the total number of cases of COVID-19 from the highest within the city, it was Queens is the highest borough. Second, it was Brooklyn, and then Manhattan. But again, the overall deaths were highest in Brooklyn. And you can see this depicted in the graph above. Next slide. So how did we get our numbers down in New York City? Well, as you can see from this picture of the desolate streets of a once booming New York City, we did that by testing. Once we could increase the accessibility of testing, social distancing, and wearing masks. And while, of course, there are people who strayed away from the guidelines, for the most part, in our very populous city, most people did follow the rules. Next slide. So specifically looking at our redeployment efforts at SUNY Downstate, this graph I'll just walk us all through. So if you look to the green, the outermost green on the right-hand side, we were at full deployment, and that happened within the first 30 days, really within the first 2 weeks of the surge. At our max capacity, we had 196 patients who were COVID positive or PUIs, persons under investigation. And at that time, we were fully redeployed. That is that all departments, all programs participated in some effort of redeployment. We mainly focused our efforts in the ICU, the internal medicine floors. We had tents outside of both hospitals that did triaging and the emergency department, as well as the employee health, which really ended up seeing a lot of healthcare providers who got sick from COVID. We also had special teams, the proning team, as we had found that proning patients in the ICUs allowed for improved respiratory outcomes. So our orthopedic residents, our anesthesia residents, and those who are rotating in the ICU participated in the proning teams, proning patients twice a day. Our surgical teams, as the cases stopped and they were only emergency cases that were proceeding, our surgical teams lost some of their procedures that they would usually do. And so they created this surgical procedure team that helped out the ICUs with their basic and even more complicated procedures. They also helped out the internal medicine floors and then went around the hospital doing procedures. Our anesthesia residents, we created a PGY1 rotation for the anesthesia residents to act as respiratory therapy extenders. We found very early on in the surge that we were very, very short-staffed of respiratory therapists who are essential, given the amount of patients that were being placed on ventilators. And so having this rotation allowed us to create an educational experience for our anesthesia residents, where they learned vent management, but then also served as extenders to help out the respiratory therapy team, which was short-staffed. We also created a telehealth rotation through the GME office. This rotation allowed us to use residents remotely, and this was really for the residents that we wanted to protect for their safety, so those who are high risk, including those who are potentially on chronic immunosuppressive therapy, including chemotherapy, or those who are late-stage trimester pregnancy. And so they were able to work from home and still round with the internal medicine floor teams. They were able to place orders, call family members, and do other work that was essential to the team, and allowed the team that was at the bedside to really focus their time and attention on the patients and other very essential tasks. So as you can see, we went from day 23 to day 36. Our numbers finally started to come down from that surge high peak, and we were able to return some of the residents back to their home programs. We continued to staff the ICU and the IM floors and also help out employee health. Then by day 50, we transitioned most of the residents back to their home departments, but we still realized that our census in the ICU was still very high. As a matter of fact, it maintained a high census for about 3 weeks upon returning most of the residents back to the departments. I should also mention that we created more ICUs. We are running about a 3-unit ICU, and we went up to 6-unit ICU. And so at that time, we had to maintain the number of residents that we were redeploying in the ICU while still trying to also bring the residents back to their home programs. Eventually, we have gotten down to what we are now, which is this status quo, which I'll talk a little bit more about, really, are we status quo? So some things to remember from this diagram is that we also, as I said in the beginning, we send our trainees to other hospitals within Brooklyn. And so we made a commitment to our affiliates to keep the resident numbers at the hospitals that they were already supposed to be rotating at, so that we would not pull the workforce at the other community hospitals in Brooklyn. It wasn't just our 2 hospitals on Clarkson Avenue, and both of our hospitals are right across the street from each other, that we really needed to worry about. It was the entire Brooklyn workforce. And so we made that commitment to keep our residents there, and even allowed our affiliates to be able to redeploy the residents within their comfort and their training level. As you can see from this diagram, the pendulum could always swing in either direction. And so we really created a workforce group, and we called it the redeployment group, that was created of chief residents and faculty members, including program directors and chairs, to help us design what this redeployment strategy would look like, so that if we were to resurge, we could go easily from the green area down to the blue area, and anywhere in between. This redeployment work group has been fantastic. It was also a means for us to gather together and to support one another and to really address any specific clinical issues with the scheduling that may have existed so that we could move people around. And we really did redeploy based off of our residents' comfort and their training level, so that we had residents on the IM floors who had already received an internal medicine year, prelim year. But we didn't want anyone to be working outside of their comfort level. And we also were making sure that everyone had appropriate supervision in accordance with the stage 3 guidelines. Next slide. So what does our redeployment efforts look like in the setting of the ACG&E pandemic emergency status? As you can see, as the COVID census decreased, we started off pretty immediately once the ACG&E announced the declaration of the pandemic emergency status. We pretty much started off at stage 3. There was no in-between for us because we were at peak surge, or we were getting to peak surge by the time they had announced these accommodations. And so as our numbers decreased in volume and our census of COVID patients decreased, we went slowly from this stage 3 to what we are at now, which is the binary stage, and we're, according to the indicators that Paul talked about, we are in the non-emergency status. We really did try to maintain as much of our educational requirements as possible. As Paul said, most of the common program and specialty-specific requirements were suspended, including the didactics. However, we continued. We gave all of our programs Zoom accounts that they could continue to interact with their residents. One, so that they could learn from each other, and it was this collective learning that helped us deal with a new type of patient and a new type of illness that we had all never seen before. And two, because we realized that having these weekly sessions, or however often the programs usually met, we continue that via Zoom, but allowing us to continue that was good for their wellness, for them to see each other, for them to interact within their department, especially when they were being redeployed to other departments. Next slide. So as I said, really, are we in status quo? And I think that that is still a question that we are tackling with. We haven't gotten back to our pre-COVID times, and so our patient volume is decreased below our normal. We see now that after this huge surge and spike of numbers of COVID positive patients that we saw, that we're now in this lull, this aftermath where patients are afraid to come back to the hospitals, either because they're afraid to travel, we are still in phase 2, or they're specifically maybe more afraid to come to our hospital center, which was deemed a COVID-only hospital. And though we removed that COVID-only designation, patients are still very, very fearful to come to the hospital, because in the beginning of the surge, the hospital was likely the most dangerous place for you to come. And in New York City, we tried to keep all of our patients at home and treat them via telemedicine, or even a COVID city hotlines as much as possible, with doctors covering those hotlines. So now we're kind of trying to tell the community and our patients that it is safe to come into the hospital when you need to. And we're also converting a lot of our outpatient care and even emergency department care into telehealth, so that we can continue to care for the patients who are suffering from chronic conditions. But as you can see, we still have not gotten back to 100% of our volume. Next slide. So what are the lessons we learned? And you'll see here we were featured in CNN. If you go to this site, you'll see that during the interview, our ICU director and fellowship director was almost unable to complete the interview because there were so many codes that were going on while he was doing the interview. In fact, in one day, there were about 15 codes going on. I believe that was that day or either the day after. And most of these codes led to death. So imagine a code team having to do 15 back-to-back codes. It really created a mental strain on all of our frontline care providers, from the respiratory therapists to the ED docs, the ICU docs, everyone, the nurses. patients were dying alone because we weren't able to have family members at the bedside. Even more straining and an impact on our providers were that doctors, nurses, and staff were getting sick, and even some were dying. We lost our beloved Dr. James Mahoney, who was an ICU doctor who was set to retire in December. He went in full-fledged at the beginning of the pandemic, and unfortunately, he succumbed to the virus. We also lost one of our beloved ED nurses who had dedicated 30 years of her life to caring for patients in our community. So the mental health strain of having to not only see patients die, but to see the ones you love and work with daily die was quite a bit. It was one of the first things that we needed to address. Next slide. So identifying that we needed to have a plan for the mental health of our frontline providers was essential. Kings County and H&H developed a program, and they had already had this program into existence, which they were able to really have more robust programming for, was called Helping Healers Heal. And so it included a variety of sessions, workshops, and virtual support groups. We also, from the GME office, had a resident virtual support group that met daily, and you can see the flyer above. We had a hotline for any of our staff members to call, and they would get an immediate same-day appointment with the mental health provider. We also did departmental virtual support groups for the departments that were heavily impacted, like the ICU, the emergency medicine department, and the internal medicine teams. Our local community really did band together to help support their frontline workers. We had food donated, gifts, supplies, including cosmetic supplies, shoes, brand new shoes donated from companies. It really was a wonderful sight to see. In fact, we had 250 meals come to the hospital twice a day for both lunch and dinner for about 6 weeks. We partnered with Uber and Lyft to be able to get our providers to work, especially when our public transportation started to decrease the amount of buses and subways. We had free parking around the hospital, and our medical students were essential. We had over 100 medical students who were unable to participate in clinical bedside care, but they worked as volunteers, and they were able to help and support in non-clinical ways. They also were able to collect Seamless gift cards. Seamless, I'm sure, is probably across the country, but basically Seamless Grubhub, which delivers food to your house. We got our residents' family gift cards because it wasn't just the residents who were impacted. You know, residents come from families, and so we were able to provide Seamless gift cards for those families who were most impacted. We also did a week-long celebration for graduation just last month, where we gave out certificates of courage to all of the residents. We had a virtual Instagram party for the residents, and we gave them gifts for them to memorialize 2020. Some other lessons that we learned was that frequent communication was essential. It was essential for our trainees, it was essential for our staff, and for the program leadership, including the program directors, program coordinators, and the chairs, and the chief residents. So we tried to have as many town halls as we could with myself, with the dean, and with whomever leadership from either hospital that we could gather. It really was great to be able to talk to them and to give them the most up-to-date information that we had. Even if that information was that we don't know right now, just being able to communicate with them as frequently as possible was essential. Next slide. And so another very, very important lesson that we learned was centered around PPE. There was a nationwide shortage at the very beginning and probably even in the middle of the surge of PPE. And there was a fear that we were going to run out. We found that keeping our frontline providers, particularly the trainees, safe with an adequate amount of PPE was essential not only for their physical health, but for their mental health. All in all, about 3% of our trainees were infected with COVID, which is a very low number, considering we have about 1,000 trainees. And we are, very proud that we were able to keep everyone essentially safe. We had one person who was hospitalized with COVID pneumonia. She was discharged within a day, She stayed home for about a total of 4 weeks, and then she was well enough to be able to go back to work. The PPE was not only the efforts from the city, from the hospital, but it was also from the residents and fellows themselves. The internal medicine residents were able to raise $70,000 in a GoFundMe that went towards the purchase of PPE. The surgery residents were able to secure N95 masks. The dermatology and ophthalmology residents got 600 reusable gowns donated from the garment district. And the emergency medicine residents were able to secure a $500,000 Jack Rudin grant that went towards buying the lab testing equipment, PPE, and other wellness activities. So the important lesson for us now to learn, not only in Brooklyn, but nationwide, is to stockpile PPE. In fact, Governor Cuomo has made a mandate that all hospitals have at least a 90-day supply. Next slide. So we're all facing two pandemics, and we particularly felt that here in New York City. As you can see from this 8 minutes and 46 seconds that it took to kill George Floyd, our residents in our community wanted to respond, and we wanted them to have a voice because we're not just physicians, but we are members of that community. And so the GME wanted to respond to stand alongside our patients, our residents, and our medical students. Next slide. So the residents called me and they wanted to do a die-in demonstration. And within 2 days, we gathered, we were able to gather for this die-in demonstration over 100 people, residents, medical students, faculty, and staff. We asked them to kneel, lie, sit, whatever they were able to do, in solidarity for our community to fight against racial injustice and police brutality and health disparities. Because in fact, it was this community that was hardest hit, as I had described earlier, Brooklyn, from the COVID-19 pandemic, and that is really because of the health disparities that exist within our community. Next slide. So we felt that it was essential for us to also speak out on another pandemic, and that's the racial injustices that we see in our community that also impact this same community. You know, they woke up one day and they had to deal with a pandemic. And then after they survived that, they had to wake up again to view a video and to see all of the other aftermath of racial injustice to be highlighted. And so we felt it necessary for us to respond. Next slide. And so what do we do from here with this second pandemic? Well, we really do feel like it is one to acknowledge that it is a pandemic, and though it's been generations on generations of racial injustice, it is now coming to the forefront and floating to the surface and really impacting our patients, our community, our residents, our staff. And so our GME office is putting together a Diversity and Inclusion Resident Council, which we hope to be able to provide mentorship, community engagement, education, and really focus on recruitment and retention of a diverse workforce. Our institution is also creating an equity and social justice workforce so that we collaborate across our campus with all 5 schools to be able to tackle some of the social injustices that are happening within our communities. We really want to show our residents and be role models for our community, not only inside the hospital walls, but outside. Next slide. So Martin Luther King said, only in the darkness can you see the stars. Our residents have risen to the challenge and they have been true heroes. And I would be remiss if I didn't thank them for their hard work, their dedication, and really their inspiration. And, you know, they were probably much more leaders during this time than any of us were. So since May, every night in Brooklyn, there are fireworks. Now they are illegal fireworks, and the governor and mayor are trying to stop them, but it really is a wonderful sight to see. People are celebrating survival, and we here in New York City have been through quite a bit over the last few months, and to see the celebration of survival, it really is an acknowledgement and a testament to the community. And as Governor Cuomo likes to say, we are New York strong. I also would like to thank the support of Greater New York Hospital Association and the ACGME. We've had weekly DIO calls And this really did create an environment for us to use our collective knowledge to help fight this pandemic so that we didn't feel like we were fighting it alone. So thank you, and I look forward to taking any other questions during the Q&A. And I'll pass it along to Vanessa. Thank you.
Thank you, Teresa. Now it's time for the Q&A portion of today's webinar. We are a little short of time. We have about 5 minutes. So if you have a question, please use the raise your hand function to let me know to unmute your line and announce you. As I mentioned at the start of the call, you also may use the chat function to ask a question. A question that we have for you both, Teresa and Paul, is what advice do you have for hospitals who are not in emergency status but have had to delay or make changes to our educational approach to assure resident and patient safety?
So I can, this is Paul. The one thing that I would ask those who are listening to take away, and this is something that I'm kind of passing the voice of the DIOs on, and I believe in this a lot, the command centers in clinical environments, the DIO needs a seat at the table. They are the person who understands what's going on with learners in the organization and faculty members. They have so much to offer, and as we look to really kind of fight the pandemic, the integration of the educational enterprise with the clinical enterprise is so important, and DIOs are such an important person to have in the room.
Great, thank you, Paul. We have another question here. This question is for you, Teresa. This question states, beyond the protest, what type of support or actions is the hospital taking to help residents manage the disparities unearthed by COVID-19 in conjunction with the wider racial injustices and equity issues?
So as I highlighted, we have created a equity and social justice work group. And so we have a list of action plans that we are working on and have been distributed throughout the chairs so that we hope to have an impact and really engage our local communities. One of the efforts that we engaged in this week actually was a demonstration for the maternal mortality and the women of color, and to try to help keep our services here in Brooklyn and not centralize the care, so that it doesn't leave the borough. And it's community outreach and community projects such as that we're hoping to work on and collaborate with all of our partners throughout the entire schools, as well as both institutions and the community.
Great, thank you. We have a question here for you, Paul. This question states, how do I get to the DIO and well-being communities? Are all the resources publicly available?
So the answer to that is not at this time. If you go to the ACGME website, there is an icon in the top kind of banner on the page that says "Learn at ACGME" with the ACGME logo. If you go there, there may be some things that are available. If you can, I believe you can create a login. There may be some things that are available publicly. The materials that I described are materials for designated institutional officials and institutional coordinators. You can ask your local DIO or institutional coordinator if there are resources you want to see. Please feel free to write to me, and we can back channel. There may be things that I can do to get access to things that you may want to see.
Great. Thank you, Paul. Looks like we have time for one last question. This question is for you, Teresa. The question states, who was represented on the redeployment work group? Was it staff type, departments, question mark?
So we had our associate DIOs, which are program directors in the Department of Surgery, radiology, and pediatrics. We also had internal medicine program director and chief residents, and the emergency medicine program director and chief residents. And then we invited any of the other chief residents that would like to participate. So we had a large collection of, our large programs like internal medicine, pediatrics, and emergency medicine and surgery who participated, but they also helped to gather some of the other programs who may be small in numbers, but were also impacted by the redeployment. We also had administrators at both hospitals. It's really important to involve all your affiliated hospitals if you have hospital systems, and myself that were leading.
Great. Thank you, Teresa and Paul. And with that, we conclude today's webinar. Just a reminder that we have a new COVID-19 email list for members, so please visit the COVID-19 resource page of our site to sign up. It's a great way to continue the conversation and ask additional questions related to this webinar. Here is contact information for today's presenters in case we couldn't get to your question today. Also, please keep an eye out for an email from us tomorrow that will contain a link to our brief evaluation form. Please share your thoughts, which can help us to ensure our webinars best meet your needs. The email also will contain a link to a page with a recording of and materials from today's webcast. We are happy you were able to join us today for this webinar, and we hope you can join us in August for another great virtual experience, Virtual Vital 2020. Virtual Vital offers an unparalleled program with multiple daily education sessions focused on executive leadership, policy and finance, population health improvement, and innovative care solutions. For more information, visit our website, vital.essentialhospitals.org. Thank you again to our speakers and to our audience. Enjoy the rest of your day. Goodbye.